Yes, so very good evening. Just let me know if the audio and video is fine. So today I have been able to gather more questions. So as students have sent more questions, and now with the better options and the further correct choices. So still, if there is any query, you can let me know, right? And I'll keep on seeing the chat as well. And if you would like me to improvise any choices further, just let me know, right? So once again, I welcome you all to this physiology discussion of the INICET exam which happened yesterday. There were around 12 to 13 questions. Some were overlapping with like a Nobel Prize question was overlapping with the medicine and the other subjects as well. So let's start with the first question, right? So the first one, yesterday we were talking about absorption, but it was not absorption. Actually, they had asked that least amount of sodium is present in which of the following secretions, right? So they were asking that least amount of sodium is present in which of the following secretions. So actually there was a confusion to some people who were suggesting and were rather confused between the saliva and the colonic secretion. But as far as I can find out by looking at your options which you have sent me further, so what I could find is that actually the saliva was given rather than colonic secretion. So I would say if saliva was the option, salivary secretion was given, then I'd like to show you a table today which has been taken from a research article. So if you look here, these are the compositions of various ions in the various GIT secretions. So if you look at this table, this has been taken from ResearchGate, which is an established journal. So if you look here, you will find that the salivary secretion has actually the least amount of sodium, right? Least amount of sodium and maximum amount of potassium. Fine. So the answer to this question, the least amount, is actually the salivary secretion, right? So the answer was salivary secretion. So this is the reference. You don't have to remember these values, but definitely I would say that keep a track of the idea that maximum potassium ion concentration is in colonic secretion, maximum potassium amount is in saliva, and least sodium amount is in the again salivary secretion, right? Now moving on to question number 2. So as we go to question number 2 now, the following kind of left ventricular pressure volume loop is seen with. The following kind of left ventricular pressure volume loop is seen with. Remember, 3 loops we always do in classes, also done in back to basic recording as well. If you look at I'll draw quickly all the 3 for you. If this answer is actually increase in afterload or increase in total peripheral resistance, answer is actually C, because remember what is happening here is because there is more afterload or more increase in total peripheral resistance, the ventricle is trying to increase the left ventricular pressure but not able to pump the blood. That means stroke volume in comparison to normal has reduced. Had it been increased contractility, then the students argue that can sir it will again be upward shift. I would say yes, definitely, but please have a look. Then the loop should be like this. This will be my loop where it is no doubt upward shift, but the more important thing is because of increase in contractility now, the loop is shifted towards the left because I am able to pump in more stroke volume in comparison to normal. So here my stroke volume is actually increased in comparison to normal, right? Stroke volume is increased. If stroke volume is increased, then naturally the end systolic volume, this one, will be reduced, right? So stroke volume is increased and the end systolic volume will be reduced. And had it been increase in venous return or increase in end diastolic volume, then the loop will be showing me a totally different picture. This is my end diastolic volume increasing like this. And now I can say certainly the loop is going to become like this. So this green one is for the increase in VR, venous return, or increase in EDV. That means the loop is shifted towards the right. Aortic compliance is not going to affect the left ventricular pressure volume loop, right? So here the answer was increase in afterload or increase in TPR, right? Same as increase in afterload. Yes, sorry Aditi, just let me. Okay, so Aditi is saying that only the pressure was increased but stroke volume was shown same. Okay, so okay Aditi, I'll redraw for you. So that means the figure is somewhat like this. Fine Aditi, taken your point. So let me quickly improvise the figure. Suppose let's say this is the normal one being shown like this. Yes, this Aditi, I'm coming to your point. This is the normal one and we are saying that the loop was, let's say, somewhat like this, right? So now the left ventricular pressure was increased but the stroke volume was nearly same. Please remember, then also I would say the increase in afterload. Yes, Aditi and Vaishak P, I am coming to your query. So again I would say the better answer is increase in afterload. The reason is if there is increase in contractility, 100% the stroke volume will increase, right? But if there is increase in afterload, the ideal situation is that the left ventricular pressure will increase and the stroke volume should decrease. But if it is maintained, then also, yes, Buster Medicine, I am coming to your point, it can't be increase in contractility. If I have to choose amongst these options, then the best answer is still increase in afterload, because with increase in afterload, in the initial part, the left ventricular pressure can maintain the stroke volume, but eventually the stroke volume will reduce. So yes, the answer still would be increase in afterload, although I can agree with all of you that it was not an ideal curve, right? It was not an ideal curve. So it was something like this one. Yes, Buster Medicine, taken your point. I'm agreeing with you all that the loop was like this. Only left ventricular pressure was increased, but stroke volume was nearly constant, right? Same. But still, I would say the answer still will remain afterload. The reason is if there is increase in contractility, when you give digitalis, 100% stroke volume will increase. Plus, left ventricular pressure will also increase. So it can't be the same stroke volume. With increase in venous return, the end diastolic volume has to increase, which is according to all of you was not shown in the picture. So by elimination, I will still say that it is an initial part of increase in afterload or TPR when the left ventricle is still able to maintain the stroke volume, right? Let's move to question 3 now. With this, I did not discuss yesterday because the exact language was not, with me. So today I have been able to get this question. Which of the following hypothalamic nuclei is involved in leptin resistance? Okay, Buster Medicine, Vaishak, let's move to the next one. So yes, leptin resistance. Remember, I'll show you one picture which I have discussed in the B2B videos this year. So this question is actually coming from there. Leptin is released from the adipose tissue. It has various roles. First of all, leptin acts on a nucleus known as arcuate nucleus. Because of the action of leptin on arcuate nucleus, it decreases the food intake and increases the energy expenditure. overall resulting in decrease in body weight. Decrease in body weight. So now lot of you had this confusion that answer should be ventromedial. Please understand, ventromedial is the nucleus responsible for satiety, but it has nothing to do with the action of leptin. So let me show you the picture which I have exactly taken from the workbook. This is beyond the workbook topic. If you again look there, this is the hand-drawn picture which I have shown you this year in the B2B videos, right? This is the part of extra topics or beyond the workbook topic, where I have shown you this regulation of feeding or control of the behavior of feeding in humans. There were various hormones. This is the same hand-drawn picture I have taken from the videos. So if you look carefully, this is the arcuate nucleus. In the arcuate nucleus, we have the action of various hormones. We have the insulin peptide YY, but my concern is now leptin. So it is leptin and cholecystokinin. But leptin, what it does is it acts on the arcuate nucleus. It stimulates a particular center known as, or the pro-opiomelanocorticotrophin neurons, which then stimulates paraventricular nuclei, which causes decrease in food intake. And this is the reason the arcuate nucleus is the better answer and not the ventromedial nucleus, right? So, and remember, I had myself told you that these are beyond the workbook topics, are mainly important for INICET, and you have the proof yourself. The question has now come in the INI exam, right? So these beyond the workbook topics, specifically as I have mentioned in the videos also, that in case you are targeting INICET, you must do them, right? Feeding behavior, high altitude physiology, deep sea diving. Although there weren't any questions from high altitude and deep sea diving this time, right? So the answer has to be arcuate nucleus. Remember, lateral is absolutely wrong. Lateral is again a nuclei responsible for excessive feeding. Ventromedial causes satiety. That also I have told you. Leptin has nothing to do with the action on the ventromedial or lateral. Same goes for anterior. So the answer is arcuate nucleus. Moving on to question 4. This is again repetitive nerve stimulation. So this must have been discussed by a pharmacology person. If not, then let's find out the answer. So I am failing to understand what is the controversy here, because it's a simple one-liner which again I keep on telling you in classes as well, that repetitive nerve stimulation shows decremental response in myasthenia due to exhaustion of the neurotransmitter. That means as I keep on stimulating more and more, my acetylcholine stores are depleted. So please understand, people are saying that answer should be A, but please understand this is wrong. The reason is this is the pathophysiology. I am not asking you what is the reason for myasthenia here. I am asking you, if I keep on stimulating again and again, then why is the response reducing? So the best answer is there is exhaustion of the neurotransmitter. So neurotransmitter stores are depleted. Exhaustion or the depletion of the neurotransmitter stores. So please remember, 100% this should be the answer, because although because in most of our books this is mentioned as the answer, and it cannot be the decrease in number of acetylcholine receptors, because that is the pathogenesis of myasthenia. Also, this is, we all know, LEMS, autoantibodies blocking the presynaptic calcium channel, which is the Lambert-Eaton myasthenic syndrome. Degradation is not affected here, so this is naturally wrong, right? So the answer is exhaustion of the neurotransmitter, acetylcholine depletion. You are saying with repeated number of stimuli, free number of receptors will be low. With repeated number of stimuli, I am saying that there will be a depletion or the exhaustion of the neurotransmitter. Please understand, the number of receptors there is autoantibodies to the acetylcholine receptors and they are eventually exocytosed. So we say there is decrease in number of receptors and the acetylcholine released is less, so it is naturally going to bind to the lesser number of available receptors, right? But I would say that exhaustion of the neurotransmitter is better according to me, right? So I can reconnect myself with the medicine person as well, and if there is any change or any inputs from him, then I will definitely change this question and let you know all, right? So don't worry. Which of the following neurotransmitters is correctly matched with its site of synthesis? Now here also there is a little ambiguity, so please let me know, were these the actual options given, or do you think that some other option was given? Yes, double A. Harshit, when we give acetylcholinesterase inhibitor, then the acetylcholine will remain bind to the acetylcholine will not be degraded. It will be bound to the receptor for a longer duration, resulting in the opening of ligand gated sodium and potassium channels for a longer duration, resulting in the better production of motor end plate potential, eventually improving the neuromuscular transmission. So when we are giving acetylcholinesterase inhibitor, then the acetylcholine remains bound to the receptor for a longer duration. That is the reason, right? Yeah, I know this is, people have made it as a controversy and I'm totally getting your point. Okay, double A, multiple correct and different options. Can you help me out? Multiple correct and different options. What were the options? Are the options matching here? Yes, because if it was multiple correct, then maybe I need to change the options. Can you recall anything? Although I know more than a day has passed. Not this matching. Okay. Fine, double A. If you can improvise and help me with the question better, that would be really grateful. Okay, that busted medicine, I got your point. But if I want to change, then I have to give over here something like, instead of basal ganglia, maybe we can give, I can write down all the correct answers and then we can find out. So acetylcholine, the best answer would be yes. Over here, serotonin is given as correct. And acetylcholine, the best answer is nucleus basalis of Maynard. Okay, somebody is saying which is not correctly matched. Fine, if it was multiple, then let me say this is now correct for this one. Dopamine again, yes, locus ceruleus is for norepinephrine. No problem, double A, doesn't matter. Yes, and dopamine substantia nigra, right, pars compacta. So now we know all the correct ones, and in case they had asked you which is, okay, acetylcholine was nucleus basalis, then it is correct. When it is correct, double A, then it is correct. So let me change the options. If I say acetylcholine is nucleus basalis, as you are saying, and multiple correct were there, then I would go with the option A and B both are correct, right? A and B both are correct. If that was the one, you are sure about it. But if there is ambiguity, then let's leave it to the question which I have told you. At least you now definitely know all the normal, their main areas of their site of synthesis. So if the acetylcholine was given as nucleus basalis, then definitely that is the correct answer, right? So double A, if you are sure, I am agreeing with you. Moving to this one, identify the agent blocking this transporter. This I don't think there is any ambiguity or controversy here. Yesterday also we were able to gather the answer to this question. The one which inhibits sodium potassium ATPase is none other than digoxin digitalis, right? So digoxin is a blocker. No pars, okay, blocker of the pump. Okay, double A, fine. Don't take too much stress. At least you remember the options, and I hope that you have marked it correct, right? So all of the following are seen in Conn syndrome except. Now, please let me know, were these the actual options? Because some of you are saying that the options were not this and there were slightly different options. So can you recall here? This must have been or will be, I think, discussed by the medicine person. Yes, all of the following are seen in Conn syndrome. So if I have to choose amongst them, then my life is easy, because you know that hypernatremia occurs, hypokalemia occurs, hypertension, but acidosis is the wrong answer, because here alkalosis occur. Okay, Harshit. But now some of you were telling me that even the alkalosis was given. So please, first of all, let me know, was the alkalosis was there? Okay, Busted Medicine, thank you for giving your input. Okay, thank you so much. Thank you. So now I change this option. Okay, I change this to alkalosis. Fine. I agree with you all. Thank you so much. So if alkalosis was given, then let's see what should be the answer. So now what should be the answer? Hypernatremia, hypokalemia. So remember, increased potassium secretion. This will definitely occur. Yes, thank you. Increased hydrogen secretion. This will also occur. Hypertension also occurs. Then I would say the answer is hypernatremia, because sodium levels do not increase much. Okay, double A, thank you. I have changed the options. Thank you. Hypernatremia should be the answer. The reason is, in primary hyperaldosteronism, in Conn syndrome, in primary hyperaldosteronism with excessive aldosterone, there is increased sodium and water retention, but you know that this causes increase in atrial filling, which will cause release of ANP, aldosterone escape phenomena. Because of release of ANP, hypernatremia is not much. So hypernatremia should be the answer, right? If you were saying, which I'm agreeing with you, that alkalosis was actually given along with low potassium, low hydrogen, hypertension, then hypernatremia is the best answer. Yes, and people are agreeing. That's good. Cortex responsible for scanning of visual field. To tell you frankly, this we don't teach in physiology. This is basically dealt by the optha faculty. So here, according to our books, the answer or scanning means the saccadic eye movements. So saccades or the saccadic eye movements, the area responsible for the saccades is frontal lobe, right? That is the best answer given in the our Guyton, Genong as well as the ophthalmology books. Although I will, to tell you frankly, this we are not doing in physiology, because this is considered both special senses, ENT and ophtha are the separate subjects altogether, right? So frontal lobe is the answer still, because saccades or the saccadic eye movements, this is due to frontal lobe. Then this again, I think there is no controversy here. Patient has severe acidity. Imaging shows a small nodule on the medial side of second part of duodenum. What will you check for further in this patient? This is Zollinger-Ellison syndrome. Again, overlapping question with pathology as well. So answer is none other than gastrin, right? So here I again don't need to talk much about it. Coming back to this question, now some of you were telling me yesterday that it was sodium potassium pump given, but then many of you told me that actually it is P glycoprotein, and there was some figure given. Figure actually I could not get from any one of you, so I have not put the figure here. But answer as discussed yesterday, this is the secondary active, this is facilitated diffusion. Organic anion transporter protein could be an anion exchange. P glycoprotein is the answer here, because they belong to ABC, which is ATP binding cascade of proteins or ATP binding cassette proteins. These proteins, they are example of primary active. Yes, absolutely correct, Shashikant. GLUT2 is facilitated diffusion, you are correct. But ATP binding cascade of cassette proteins, they are primary active. They directly use ATP to push the substrates out of the cell, right? So they directly use the ATP to push the substrates out of the cell. So here the answer was okay. Thank you so much. So answer is P glycoprotein. Let's let's see the worst possible scenario. Let's say you were not clear about the the answer. Then also by elimination, I feel that you should have got it correct, because SGLT1 is naturally co-transport of sodium and some other ion, which is not shown according to AA, as he's telling me. GLUT2 is again facilitated diffusion. That also you rule out. Organic anion transporter protein is something like, as we study in chloride shift and ion exchange, that again requires 2 ions. And P glycoprotein, by elimination you could have also found out the answer. It is a type of, right now I'm telling you, it's a type of newly discovered ABC proteins, as they are known as ATP binding cascade of proteins, which directly use ATP to push the substrates out of the cell, right? Yes, thank you. Question 11, again overlapping with medicine. This is also done in cardiovascular physiology. Pulsus paradoxus, yes, you are right. Systolic blood pressure falls slightly during inspiration because of. Basically what we say is that during inspiration, right side of the heart, left side of the heart. So the difference is, during inspiration there is increase in venous return. What happens is the intrathoracic pressure becomes negative. Also the diaphragm descends downwards. There is increase in intra-abdominal pressure. So this pushes onto the veins. On the right side, there is increase in venous return to the right side of the heart. Okay, decrease left ventricular filling was the option. Thank you. I'll change that. Rest option same. Okay, AA. So decrease left ventricular filling. Then increase venous return towards the right side of the heart. What is happening here? And on the left side, the pulmonary veins have a very high compliance. That means they can stretch a lot. If the pulmonary veins have very high compliance, they hold a lot of blood volume, resulting in decreased blood flow into the left side. Because pulmonary veins have a very high compliance, they can stretch a lot. Naturally, if there is more venous return to the right side, suppose we are talking about the heart like this, this is the septum, then because of the increased blood volume, I am going to push the septum from the left to the right side, resulting in less left filling, left side filling, because it is being pushed, septum is pushed towards the left side. Also the reason is pulmonary veins have more compliance, they will stretch a lot, resulting in decrease in left ventricular output, which is further going to cause a fall in systolic blood pressure. Now if you are saying the rest options were same, let's find out the answer. Increase systemic vascular resistance, no. Decrease pulmonary compliance, no, it should be increased. Then decrease left ventricular filling or increase venous return to the heart, causing transient decrease in left ventricular filling. So remember, the better answer is option number D, because there is more venous return to the right heart, It is pushing the septum towards the left side, resulting in decreased left ventricular filling, right? So as if I agree with you and say that the option number C was actually decreased left ventricular filling, then the better answer is because of more venous return to the heart, the septum is pushed from the right to the left side, resulting in decreased left ventricular filling, right? Although a lot of you are also telling me that it is actually increased left ventricular filling, but I'm agreeing with you right now, right? It was decreased. Yes, AA, I got your point. Moving on to the 12th one, which of the following represents most stable? This question also we did not discuss yesterday. Most stable and long-term mechanism of homeostasis in the body. Remember, here you only have to use one fact, which I tell you always: long-term and most stable. This is one of the pet questions of INICET. If you could recall, which system has infinite gain? Can you recap? Which system has infinite gain? Infinity. Infinity gain means what is gain? Correction upon error. Correction upon error. Remember, there is only one system which has infinite gain because it has zero error. That means it does always 100% correction. There is infinite gain, there is zero error. Absolutely correct. Role of kidneys in control of ECF volume. Role of kidneys in control of ECF volume. This I would expect that all of you got it correct. Role of kidneys in control of ECF volume. So urine output, right? So they had wonderfully changed the language of the question to make it a little complicated, but basically they are asking you homeostatic best mechanism. Best mechanism would be the mechanism which has no error at all. Which is the only mechanism which has no error at all? Remember, all mechanisms have some error. Respiratory rate, respiration, some error would be there. Tachycardia, sweating will be not the long term, it would be short term. Tachycardia, again, it is not going to correct. Baroreceptor, as you know, results in tachy or bradycardia depending on my position from, if I'm going from standing to supine, then what will happen? My BP will increase, then the baroreceptor will try to decrease. If I'm going from supine to standing, then what is going to happen? My venous return decreases. I will have tachycardia to restore the blood pressure. But gain of baroreceptor is around -4. Thermoregulation is also -33. But only kidneys have infinite. This is a question now, a simple one. This was just announced around 3 weeks back, and 2025 Nobel Prize in Physiology was awarded for. So it was awarded for the peripheral immune tolerance. Again, I hope you all got it correct, because these are the recent advances, and this year's Nobel Prize they had asked, which everyone is or should be aware, I would say. Just to tell you, this has been announced recently, and the 3 scientists who are the Branco, Ramsdell and Sakaguchi. These are the people who have discovered peripheral immune tolerance. Their work has identified the Tregs or regulatory T cell which prevent my immune system from attacking the body's own tissues. So basically Sakaguchi is the person who was honored for the discovery of regulatory T cell, while the other 2, Branco and Ramsdell, have recognized a gene known as FOXP3 gene that controls these cells. So actually all 3, the trio got the okay. T cell immune regulation, if that was the answer, still it remains the correct answer. So I will agree with him if he's saying that T cell immune regulation. Okay, perfect. Thank you so much. Then which of the following processes most significantly affects the magnesium metabolism? This I would say is a slightly tricky question. You could do it by elimination, that magnesium is around 60 to 70% reabsorbed in the thick ascending limb of loop of Henle. Other tissues are also playing a role. Today I am going to show you one picture taken from the ResearchGate article, and this is the latest information what we have. So let's have a look over here. So this is the latest one. What they are showing is that in the diet I am taking 12 millimole. Then from the intestine, the 8 millimole, right? the digestive juice has around 2 millimole and total intestinal absorption is only 6 millimoles. Now please look at the kidney. In the kidney, 84 millimole is filtered, but 80 millimole is reabsorbed. So naturally the tissue which is playing the maximum role here is none other than my kidneys. 80 millimole is reabsorbed, right? So this is again taken from a research article published in one of the journals, and I would say that even without this knowledge, as I had explained you yesterday in a simple way, that in the thick ascending limb of loop of Henle, the potassium is moving out via ROMK, which makes the luminal potential positive, repels the calcium and magnesium, and paracellularly plays a major role in magnesium reabsorption. But I would like you to know the exact picture which I have been able to search today before the proper recall. So I would say that you should know, just look at, don't remember the values, but just have an idea that 84 millimole is filtered, out of which 80 millimole is being reabsorbed, right? So in the urine, only 4 millimoles. So answer is definitely the same one as we did yesterday, reabsorption from the kidneys. Then please let me know what this was, this question there in the exam or not, because some students have sent me this today afternoon only. Yes, so please, anyone, I will push double A to tell me, because he is in the mood to recall the right options for me, right? Yes. Or for that matter, anyone who is there with us in the chat right now, right? Yes. Was this question there, please, or will you like to improvise the language here? Okay, thank you. So now I'll show you one picture here. 2.5. Yes, thank you so much, Dr. Divya and double A. So answer is actually, yes, thank you. Yes, God bless you, thanks. The answer is actually alveoli, because I will like to show you one figure here. Okay, just see this, as this is a figure of the person with the upper respiratory tract and the alveoli. So particle size which are greater than, this is now for further information, you should all know, greater than 10 microns are removed by tonsils and the adenoids. What they say now is that more than 10 micron particles, basically because of their heaviness or inertia, they fall backwards into the tonsils and are removed by the adenoids and the tonsils. The particle size which are around 2.5 to 10 micron, or generally we say 3 to 10 micron. Okay, fine, thank you. I am just coming to it, right? They are removed by coughing and mucokinesis, the cilia gel mucus mechanism, and the particle size which are less than 3 microns are removed by the dust cells. Please listen double A now carefully. Dust cells are your PAMs, pulmonary alveolar macrophages. And now you will agree with me that the answer has to be alveoli, right? Pulmonary alveolar macrophages. These are known as PAM cells, right? PAMs. So basically these days, as you know, pollution is going around in Delhi NCR. So with a lot of pollution, what we say is these less than 3 micron, 2.5 micron particles, they are being ingested by the pulmonary alveolar macrophages as a defensive mechanism, which can result in long term fibrosis of the alveoli and the lungs. That is why it's a grave or serious situation. So if it was given only deposited, answer will remain alveoli, but this is for your further information that less than 3 or 2.5, less than 2.5, generally we say are removed by the dust cells, which are PAMs, pulmonary alveolar macrophages, right? So less than 3 would naturally mean 2.5, right? So they are deposited in alveoli, that's fine, but who will remove it, right? Pulmonary alveolar macrophages. Yes, I am totally agreeing with you. It was deposited. Yes, Harshit, 1 to 5 are Robbins gives that. You are correct. but what I could gather is that less than 2.5 are actually deposited in the alveoli. 1 to 5 will come in the category of around 3 to 10, which body still tries to remove by cuffing and mucokinesis. But less than 3 or 2.5 to 2 microns are the dangerous ones because they are directly deposited in the alveoli. They are able to escape the mucokinesis and cuffing. Yes, Harshit, I'm agreeing with you. But according to what I could gather, the best answer is removal by the dust cells, which is PAMs, pulmonary alveolar macrophages, especially for the particle size 2.5 and less. Right? So this brings us to the end of the discussion. Answer has to be alveoli, Harshit. Answer cannot be anything else. And they are removed by PAMs, which are pulmonary alveolar macrophages, right? And finally, I would say that there are things that happen and there are things that don't. 99% of the times we worry about the things that don't happen. So please, what has happened for good, right? Relax for some days. Take your own times. Try to set your pace for the NEET PG, which we don't know when it is going to happen, but still. And what has happened, please stop worrying about it, right? So you are done with the exam, and I could see that out of these, around 14-15 questions, I am certainly able to believe all of you that most of you got around 10 to 12 correct out of these. Very good, Buster Medicine. Then I'm expecting to see your interview soon, right? Wonderful. That's so heartening to know. So heartening. You have to tell me your rank, right? Once the result is out within a week, and I'm hoping to see your interview soon, right? Yes. God bless you. God bless you. Thank you so much. Right? So please don't worry about, just chill and relax for a few days now, right? And before you start again. AA 160 plus is again a very good score. 160 plus is a good score. You don't say any chance. You have a very good chance, right? So 160 plus is a very good score. Yes. And you also share the rank with me. Thank you. Thank you so much, right? So God bless you all once again, and right? So please look at this Venn diagram, and right? So look at this one and don't worry about, right? So what we worry about usually don't happen. So please, right? Stop overthinking, right? Take care. God bless you all once again. Thank you so much.